Welcome to Medicine Handy Point. Today we will discuss a topic relating to a patient with a polyuria. We'll discuss in this lecture how to take history from a patient presenting with polyuria. First we will define what is polyuria. Polyuria is actually the passage of 3 liter or more than 3 liter of urine per day. So that's the definition. So where are the problem? Either there is inability to concentrate the urine, means the patient will be unable to concentrate the urine by not releasing ADH, or the ADH which is released will not be acting on the kidneys, just like in case of diabetes insipidus. Then maybe there is osmotic diuresis going on, so uncontrolled diabetes can lead to polyuria, diuretic can lead to polyuria, and CKD also causes polyuria. Primary polydipsia means the patient is taking a lot of water. Either it will be psychogenic polydipsia or habitual excessive drinking. Now, so how we will start the history? We'll ask about the onset. A sudden onset of polyuria is likely cranial diabetes insipidus and most likely as a result of head trauma or post-surgical for any neurosurgical intervention. And if the patient after the surgery is presenting with polyuria, it could be cranial DI, diabetes insipidus. Next, we'll ask about duration. Then we'll ask about the characteristic of polyuria. We'll ask the patient how many times a day you have to pass urine. We will ask about nocturia, how many times you have to wake up at night to pass urine. Nocturia is sometimes the first sign of CKD, or it could be the sign of obstructive uropathy like enlarged prostate or some bladder problem. So we will ask about. Then we will ask, do you wake up at night to drink? As diabetes insipidus patient has a special liking for cold water, so they wake up at night to drink cold water, while people having primary polydipsia, they do not wake up in the in the night. Then we'll ask how much fluid do you take since waking up, including how much tea and coffee. So, and if the patient is alcoholic, so we'll ask about the alcohol, how much alcohol the patient takes. So, then we will go on to the etiology. After asking the characteristic of the polyuria, we will touch the etiology. So the common things are polyuria can occur because of the urinary tract infection. So we'll ask about the urgency, frequency, burning maturation. It can occur because of the benign prostatic hypertrophy in the male patient. So we will ask about urgency, hesitancy, poor stream, nocturia. We'll ask about symptom of diabetes mellitus, so polyuria, polydipsia, weight loss, biliary vision, nausea, vomiting, abdominal pain. Diabetes can have a lot of symptoms. Then we ask about feature of anterior pituitary hypofunction, because if there is problem over there, there will be definitely some problem with the release of ADH. So what are the features of the anterior pituitary hypofunction? There will be loss of body hair, reduced libido, impotence in males. In female, we will ask about amenorrhea, hypothyroidism features like constipation, weight gain, and choline intolerance. We'll ask about nausea, vomiting, abdominal pain, and dizziness, ACTH deficiency. So we'll touch all the anterior pituitary hormones hypofunctions. Then we touch about other CNS problems, like we will touch upon hypothalamic hypofunction, which can be present in the form of galactorrhea. Galactorrhea. We will ask that, do you have any discharge from your nipple? Because uh, because what happens that oxytocin is released from the hypothalamus, and if the uh, and dopamine sorry oxytocin, which is released from the posterior pituitary, is inhibited by the dopamine from the hypothalamus. So if hypothalamus is damaged, dopamine will not be released, and there will be continuous secretion of oxytocin and prolactin from the pituitary, and which will lead to galactorrhea, which is the milky discharge from the nipple. So hypothalamic hypofunctioning in the form can present in the form of galactorrhea. So we'll ask question about that as well. Hypothalamic hypofunction can present in form of weight gain. If there is damage to hypothalamus, the satiety center may be damaged, and the patient will be eating a lot of food. So we will ask about that. Then we will ask about nausea, vomiting, visual disturbance, and frontal headache, which may suggest some pituitary mass, because pituitary usually compress on the uptake chiasma, and it causes visual problem, and then it causes frontal headache as well. We'll about also a certain answer of headache, which may suggest pituitary apoplexy. Pituitary apoplexy can occur usually in a pituitary mass when there is increased blood flow to the pituitary gland, and suddenly there will be hemorrhage and necrosis, leading to headache and loss of function of the pituitary. So there will be decreased secretion of ADH. We'll ask about fever, neck stiffness, and photophobia. Uh, so when there will be fewer neck stiffness as photophobia, which will suggest meningitis, and meningitis can lead to cranial diabetes insipidus. Recent head injury will ask, it also leads to cranial diabetes insipidus. Then we will ask about the respiratory condition which causes hypercalcemia, which leads to nephrogenic diabetes insipidus, because hypercalcemia makes the response of ADH on distal tubules, collecting tubules, inappropriate. So the hypercalcemia actually block the action of the ADH on distal collecting tubules. So we'll ask about respiratory condition which can cause squamous cell carcinoma, cause hypercalcemia, lead to diabetes insipidus. Sarcoidosis also causes hypercalcemia and lead to diabetes insipidus. So we'll ask about breathing problem, cough, hemoptysis. In case of sarcoidosis, we'll ask about red eyes because it causes uveitis. We'll ask about lymph node enlargement in the neck because it causes, because sarcoidosis causes lymph node enlargement. Then we'll ask about symptom or psychiatric symptoms, because the patient with mood disorder will be taking lithium, and it causes a nephrogenic DI, diabetes insipidus. OCD patient, they have predisposition to develop psychogenic polydipsia. So we'll ask about OCD. Then past history should include diabetes, BPH, head trauma, head surgery, malignancy in the lung or mets to the brain, TB, any psychiatric illnesses, TB, and TB, because it can spread to the CNS and leads to cranial diabetes insipidus. Medication history should include lithium usage, anticholinergic, diuretic use. Anticholinergic in the sense it causes dry mouth and the patient drinks a lot of water. Family history should include asking diabetes insipidus in the family, as it can run in family. Social history should include alcohol use and impact of polyuria on the life in the form of problems at the workplace and at the home as well. I hope you like the video, and please subscribe to the channel.